Thank you very much again for asking me to come. And important discovery, I realized that I don't have to put my water down here because there's a shelf here. Okay, so you know, all the degrees don't help very much sometimes. I was looking everywhere. I decided I have to carry it in my hand. I said, that's just dumb. Who designed this stupid podium? Of course. Look down and there's a shelf. So that's how science actually is, right? I mean, this is actually the problem with science, is because sometimes we get so focused that we don't see that there are some common sense things, such as a shelf on this thing, that we are missing. And this is the thing about Parkinson's disease. I've run the Movement Disorder Center now almost, well, here in London for 27 years almost, but I've done movement disorders 30 years. And in fact, after 30 years of doing movement disorders, including Parkinson's, I realized how little actually we know about what Parkinson's disease is. And this is really the issue that we will discover today in my talk. I prepared this last night, so we're going to discover it together. So let's see what I have put together for us today, because here's what Parkinson's disease actually is, isn't it? And so Parkinson's, the Parkinson's disease that I was actually taught and is currently taught and continues to be taught in medical school is this little box here. This is Parkinson's disease from medical school all the way through residency, etc. But guess what? This is Parkinson's disease, right? And so you can imagine if you take a circle and draw a Venn diagram, which we used to do when we were little children, and circle whichever part you would like. 1, 1, 2, 3, 1, 2, 3, 5, 7, 3, 2, whichever thing. And this is just a small little list of things. You'll get Parkinson's disease. And so it becomes a real problem of definition as to what we call Parkinson's disease. And hence, the update on treatment for Parkinson's disease depends on what is included in that Parkinson's disease syndrome that we call Parkinson's disease. Ah, yeah, that's a good idea. Because, you know,
Too much movement going on.
well, I can't just stand there. I mean, it's just not me. That's good. That's good. I mean, it would be, I could, hello, how are you? And that's just not me. It doesn't work. No. Yeah. And movement is important, right? So we've got to move around. Now, can you hear me, everybody? I mean, yeah, perfect. Yes, yeah. I mean, I'm loud. My voice is loud anyway, so it would have carried maybe, but this is much better. So over the last many years now, 10 years, let's say, people have tried to divide Parkinson's into, these blocks of prodromal Parkinson's disease, which includes a whole bunch of symptoms such as sleep disorder, mood disorder, gut disorder, anxiety, etc. And then the typical Parkinson's syndrome that, as I said, is just this little block of motor symptoms, and then all of these other things that occur. Now, we're never going to be able to talk about update of treatment of any of these things in any detail, because then each one of them is a separate talk in itself. But I wanted to present that to you to be able to understand the scope of what we face in our movement disorder clinic in trying to treat. And the problem is, most specialists outside of movement disorders, like psychiatry or gastroenterology, don't want to treat the mood disorder, don't want to treat the constipation, don't want to treat the urinary symptoms or the orthostatic hypotension or the cognitive decline. We have to treat all of it. And so as a movement disorder neurologist trained really only to treat this, the expanse of our therapeutic realm is very large. So the problem with updating you is that Parkinson's disease of therapy is that Parkinson's disease is different in everybody, right? And so unlike, let's say, epilepsy, where a seizure in one person is very much a seizure in another person, then we use anticonvulsants similarly. Dilantin is Dilantin. We give it to all seizure patients. That's the old drug. We use new ones. But in Parkinson's, that's not the same. How you begin, where you add an anti-anxiety drug, where constipation needs to be treated first, where the nighttime symptoms are more important than the afternoon symptoms. All of these nuances become very, very important. And so to give you an update on all of what actually treatment of Parkinson's disease is impossible. And that's why our fellowship programs are at least 2 years long, because by the time you get through not just treating the patient at their diagnosis time, but through those 2 years, you learn how the disease changes. And that's not enough because the actual life cycle of the disease is 15 to 20 years, right? And so only now, after 15, 20 years of treating many of my patients, do I see their entire spectrum of evolution of that non-static disease. What does that mean? The disease doesn't remain the same. Diabetes is diabetes. Diabetes continues to be diabetes. You have complications of diabetes, but the disease itself is managed the same way. Insulin, oral Parkinson, not the same. So PD is not the same disease, right? It's in different people. Our treatments that we currently use are all tailored to the individual and what that means. And in this very full audience, everybody potentially that may be treated by us or other movement disorder people will be on a different regimen or should be on a different regimen. There is no algorithm for treatment. And the important thing is that the situation is not just at the patient, but many other variables, which I'm hoping that Heather and I will kind of discuss. And by the way, that fireside chat will be an open forum. We'll be discussing, but please feel free at that time to ask. So there are many, many hot topics that are present in terms of discussion of update of treatment. And so I've left it open there in terms of what that might be. So let's start with some non-specific soft things. So diet. What to eat? Is there an update on that? And at this point in time, really what we counsel people about eating in terms of diet is that you should avoid high protein containing meals along with only one of the medications, which is levodopa, right? So avoid eating high protein, and we'll discuss that a little bit in the fireside chat and if the topic comes up. Other than that, vitamin B6 replacement is important in patients with Parkinson's. Not too much, but enough because levodopa consumes vitamin B6. So B6 deficiency and B6 deficiency neuropathy can occur in patients with Parkinson's disease. So we supplement that. And vitamin D, not calcium, vitamin D, 2,000 international units of vitamin D usually recommended because it doesn't treat the Parkinson's disease. But if you have a fall and have a hip fracture, then the healing process, at least the current literature shows, is better post-injury in patients that are supplemented with vitamin D. Other than that, there are no real specifics in terms of replacement of anything else in patients with Parkinson's disease, specifically for diet. Now, GI motility, which we will talk about again, hopefully in the fireside chat, is also impaired in patients with Parkinson's disease. That means how fast the gut moves things is impaired in patients with Parkinson's disease. Hence, constipation is very high in terms of a symptom to treat. Almost everybody with Parkinson's disease at some point will be constipated, even before. And then the second topic that comes up often is exercise. When, which one? I'll tell you there are a lot of claims for various types of exercises. Don't pay for anybody that says that their exercise program is going to cure, reverse, treat, etc. That's false. Does not happen. If that were the case, we would actually be encouraging people to do that specific exercise. Is exercise good for Parkinson's disease? Well, it's good for everybody. Nothing is wrong with that, right? And so a specific exercise program that claims that it is reversing or stopping or slowing Parkinson's disease progression, they are wrong, they're false. And the reason is that not because the exercise is not doing that, it's because we have no biomarker to prove that. And remember, science requires proof. And proof requires a validated measure of what it is that those interventions are doing. And when we get into the actual update of therapeutics of what has come in the last 6-9 months, we'll talk about that. So there's a recent paper on Tai Chi, but we've always known that relaxation, yoga exercises, good for all patients, including, not all people, including Parkinson's disease. So this was a recent paper from China just within the last few weeks that showed that, again, Tai Chi may be helpful. Do it if you like it, right? Rocksteady boxing, dance therapy, music therapy. So, you know, it depends on the music that you're getting therapy from, right? I have a very specific interest in music. Just listening, coming here, Alfred Brendel was playing Piano Concerto Number 21, Mozart. Neville Mariner conducting, my music. So what am I going to do? I'm going to listen to that music. And I drive every month to the Toronto Symphony Orchestra and come back at 1 o'clock in the morning because that's my music. I'm not going to go to, I've even forgotten the name of the woman whose tickets are being sold or got sold out. What is the name of that woman? Swift, yes, Swift. I don't consider that music. So, right, I mean, yeah. So you're not going to listen to that 400 years later, are you? I mean, you shouldn't be. So that is not going to work for me, right? But why is that important? Because it works for someone, but not me. So that's the important thing about any of these things. Getting someone that is not interested in doing a particular type of activity does not help them in terms of the therapy that you provide. You just get bored, right? I mean, I don't like golf. I like tennis. That's my game. Not good or bad, right? So I would rather watch Roger Federer. I go to Rogers Cup every year. That is my thing. So if I'm going to hobble around and hit a ball, I serve aces all the time, by the way, because, there's nobody at the other end. And so I play against a box. So the thing is that these kinds of programs really are important with the caveat that you must enjoy that activity. If you don't enjoy that activity, it will not help. So most of the time, what I recommend people do is find that 1, 2, 3, 5 things that improve not activities of daily living, but quality of life. What is it that you want to do? And we try to optimize our therapy to that quality of life. So yesterday, we had a patient with Parkinson's disease, newly diagnosed, and this discussion becomes very important in terms of therapy. What is activities of daily living, and what is quality of life? So in patients early on, in maybe up to 5, 7, 10 years, we aim towards quality of life. Activities of daily living are putting on socks, putting on your clothes, shaving, brushing your teeth. Usually a 3-year-old can do most of those things. So up until that period of time when the disease has progressed so much that the caregiver has got to do those activities of daily living, our therapeutic goal is to manage the quality of life and do treatment that optimizes what the person and the caregiver are attempting to do to improve their quality of life. And that may be playing tennis, maybe going to Taylor Swift's concert, maybe doing whatever it is that they choose to do. And optimization of that is the best update that currently we have. Because most of the time, over our training, we have been agnostic to that. And only recently in many diseases, including cervical dystonia and other things, that we are really focusing on using therapy, such as this mixed therapy and our oral medical therapy, to improving that quality of life, which is in our lingo called goal attainment scale, or GAS, right? So the different kind of GAS. So goal attainment scale is exactly what we ask our patients, try to ask our patients, what is it that you want to do? What is it? And the problem with Parkinson's disease is that it is a condition that progresses so slowly that many times our patients have reduced their goal attainment scale by 50%, and that becomes their new 100%. And trying to aim for that then reduces another, and that's not good. So yesterday I spent most of the discussion on what is it that this individual would want to do, and we realized that actually doing virtually nothing now and feeling that, oh yeah, I think I'm good. Yes, but because the quality of life is reduced so much that they feel therapy is not needed. Well, it is needed to achieve that goal. So the first 5, 7, 10 years, depending on the individual, remember we talked about that, that is our goal. And the biggest update in the last decade has been to achieve that. Because before that, even during my training in the previous century, we really didn't pay much attention to that. We intervened with whatever. And that's an important, and actually the most important caveat of what management has become, whether it's a multidisciplinary team, whether it's these things, or our well-established interventions, right? And so oral levodopa, of course, remains the gold standard and the most effective symptomatic therapy for Parkinson's disease. And guess what? Improvement in quality of life in the short term, right? Not activities of daily living. That, of course, is included, but most of our patients can still do that for a long, long time. And because it's, of course, accepted, it is our best drug. And anybody that tells you that any other drug is better than levodopa, again, wrong. Levodopa is not to be something that you should be afraid of. Levodopa is something that also improves mortality. The only drug in the last 60 years of all drug development that has been shown conclusively to also reduce mortality, which means the chance of you dying with Parkinson's disease. And hence, levodopa is our gold standard, has remained that. So don't be afraid of taking that drug. It is very well tolerated by almost everybody, and we try our best to try and optimize levodopa therapy. So there are other things. I mean, as I said, there's levodopa-carbic gold standard. Dopamine agonists are a distant second. There are other enzyme inhibitors, and we use other things such as antidepressants and antipsychotics, and we'll get into that a little bit in the fireside chat in terms of maybe the kinds of scenarios where those things might be available for us to use. Okay. Then I've just put one slide on each one of these things because we'll get into some of the more data a bit later. There are non-invasive therapies available, and I wanted to specifically say that these are things that have been around for a long, long time and have had benefits, such as this is called repetitive, the R, transcranial magnetic stimulation. And what this is it's a research tool that has been around for 50 years, but in the last 20 years or so, repetitive stimulation using a magnetic coil. So you put this big coil on the head and it's connected to a device. It's $100,000 for this device, and you give magnetic stimulation to the brain. And the idea behind this is we talked about oral medications as the chemistry treatment for Parkinson's disease. This is now the electrical aspect of what our brain neurons do. So they are electrochemical units. The chemistry, levodopa, all the drugs we briefly mentioned, and now the electro part. We'll get into the DBS section in a minute. That's the traditional invasive way. But in the last decade or two, much more interest has gone in to try and see if we could deliver electrical charge, chemistry by mouth, electrical charge by stimulation, non-invasively, put something on the head and stimulate. So repetitive transcranial magnetic stimulation has been approved for intractable depression in the US for many years now. Right, so even here at Parkwood, we have an RTMS unit. One of our patients recently, actually just this week that we saw, is being considered for RTMS, has Parkinson's disease for their depression, where oral antidepressants are not tolerated. The problem with RTMS is that its effect is transient, which means you've got to keep coming back to getting that stimulation. Kind of like Botox that we use for many movement disorders. There, it's every 3 months we have to keep injecting patients for whatever it might be, including PD tremor, we use it. But RTMS is almost every week, if not initially for every day, which makes it impossible to deliver in most community settings. Hence, only specialized centers are using RTMS even for mood disorder, and for Parkinson's disease also, even though the data is actually not bad, it is very difficult to administer. So in my lab, in the last little while, we've been using a device that we've built to deliver transcranial current stimulation, not magnetic, now current stimulation. This is DC, so direct current stimulation. There's pulsed current stimulation, there's AC current stimulation, there's noise stimulation. And what this is something that you can actually take home. So it's a small portable device, put electrodes on the head for 20 minutes in the area that we would assign. So we've been doing studies on this. Obviously, it's not commercial in terms of approved indication for anything, but the devices are available. You can buy them on Amazon. Right? And in fact, do that. The problem is, again, science. We haven't shown yet. So we're working in the lab to try and do this. And we're using this in Huntington's patients. We've finished studies in ataxia or balance difficulty. We've also done that in Parkinson's disease wearing off. A small study, just 10 patients. Difficult to do these studies. The idea behind this is that different than our TMS, we would actually be able to give this device to you at home. So the Huntington's trial that we just did, patients took the device home. And every day, for 20 minutes, they'd put on the electrodes in the spot, and we would, one of the fellows that was doing the study would be on Zoom, making sure they had it right, sat there for 20 minutes, did the stimulation. And the idea behind that is that in addition to oral pharmacotherapy, we give the second aspect of what our brain does, which is electrical, give electrical therapy. The problem with it is, how do you focus that electrical current? There are 100 billion neurons in the brain. We really don't have any way to focus this energy onto a specific neuron. And this is where the difficulty lies in terms of being able to really target. We're doing our best to do that. The next thing that we've done, excuse me, somebody's calling me. One of these, like I'm going to give somebody my MasterCard on the phone. I mean, really? Yeah, here's, $10,000 to whatever it is that you're calling me about. That's not happening. Spinal cord stimulation. How do they get our numbers? I don't understand this either. But clearly AI is at work. Yeah. I was saying to a colleague of mine who's very much a fan of ChatGPT. He said, ChatGPT can write a poem just like William Wordsworth. I said, but the problem is, I thought William Wordsworth actually wanted to write the poem, right? I mean, there's a huge component of saying 10,000 saw I at a glance, dancing their heads in sprightly dance. I've been to Wordsworth's house, and you can see the meadow where you would see that. I don't think ChatGPT can do, right? And so I still like to write my own poetry. So, spinal cord stimulation is something that we developed in the lab in London and pioneered that here, and it's now become a large multi-center study. We actually published several papers on this, and in fact, BBC World News had come to our lab and had a feature on patients that had this. And the idea behind this is to put an electrode set on the spinal cord and stimulate to improve freezing of gait, or what we call fog, and it was remarkably better. People that had not walked in literally 5-7 years got up out of the wheelchair and walked, and has remained. We've got 7-year data now on many of these patients. Of course, their Parkinson has progressed, and the thought has been, can we? And this is actually a surgical procedure where you have to go and implant these electrodes. But is it possible? In fact, I've got a paper to review that's sitting in my inbox from Movement Disorders on non-invasive stimulation outside for gait freezing spinal cord. One of my previous fellows, Dr. Rishi Kumar, he's in Kolkata in India, has also done a similar thing using vagal nerve stimulation. So putting a vagal nerve stimulator on your vagus nerve, which is on the left side, to improve freezing of gait by giving electrical current into. The idea behind this is there's a lot of this kind of therapeutics that are being investigated now because our oral medical therapy with levodopa and dopaminergic agents has really come to a standstill. Levodopa works remarkably well. I mean, it's fantastic. And really to improve upon that in terms of a new drug has been extremely difficult. So then we moved on to this kind of electrical stimulation, and I wanted to give you a quick update on where the field is progressing there. So Boston Scientific is doing a multi-center study with spinal cord stimulation. We're trying to develop this transcranial non-invasive technology in our lab. We've actually developed it. The device is not ours, but are commercially available. So our hope is that we're just purchasing those now, FDA approved, and using them. Moving on from just simply chemotherapy, so to say, to electrical therapy. So that's where deep brain stimulation has already been done. The first procedures in Canada, actually, when I was a fellow in Toronto, were being done then. And the idea behind DBS is that exactly what? Now, this is not non-invasive, this is invasive, using electrical pulses to modify brain activity and for treatment, really, of refractory motor complications. So here we have that electrode implanted, you're awake during that procedure, then we put you to sleep and during the same day, and then implant these wires under the skin and a pacemaker called the neurostimulator pulse generator, where we then program that. In fact, Heather's in charge of what we would call device-aided therapy along with our fellows. And the idea is to program. It's not actually programming. It's not like a computer program, but we change the amplitude, the pulse width, the frequency of stimulation, all of these things we change to try and target symptoms of Parkinson's disease. Which ones? The motor symptoms. See that little box? That little box that I showed you in the first slide, that's what we target. So shuffling of gait, speech. Obviously, you're putting things into an area of the brain that doesn't really have any other, it has an original reason why it's there. It's not for us to stick things into it. And so obviously there are going to be complications and voltage spread occurs. People have sometimes cognitive impairment. So there's very, very strict criteria for selection of who goes on to have. Only about 5 to 8% of our total 100% PD patients would qualify for this invasive deep brain stimulation. The hope is that slide before, the non-invasive stuff, many would potentially qualify for that if it actually does work and it's non-invasive, it's cheap, doesn't require a surgeon, no follow-up required. That's why the interest in the field to go as non-invasive as possible. Right? So this is DBS, and it works really, really well in those patients. And this was a data set, not new, quite old actually, from early 2015 or something, 2013, which showed that in those patients that someone like me, a neurologist, has optimized for therapy, if you do a surgical intervention, you'll still substantially improve. And these p-values, which are values of statistical significance, you can see. Quality of life, right? So quality of life, mobility, activities of daily living, emotional well-being, stigma. I mean, we fail as doctors medically. Medical therapy is the little light boxes everywhere compared to the big blue boxes. It doesn't require you to be a statistician to know that big is good, small is not that good. And so, even with our extensive training, those patients that qualify, DBS really works. And again, when we see somebody in our clinic that we think qualifies for DBS, then we go through extensive testing, cognitive testing, motor testing, et cetera, to get to the point where we perform. And then my team, Heather, and our fellows will program all of those parameters over a period of time to optimize that motor function. But in addition to the motor function, also things such as social support, stigma, communication not that good because we get that as a side effect, discomfort, all of these things. And often patients come off medicine. So if you're having side effects such as bad dyskinesia, side effects such as hallucinations, because they may be medication induced, can also get better. So DBS has become the mainstay of what we would call invasive brain stimulation in a small group of well-selected patients. And a lot of data exists now. Up to 15 years, some of our patients have done well with this. And so earlier selection, better, as long as you qualify. Right? And so here are the considerations. So, key contraindications, older age. So anybody that's over 70, 71, difficulty in doing DBS, cognitive impairment, psychosis, all of these other kinds of things. And of course, one important thing, some patients may not wish to actually have surgery, which is also fine. It's not a benign procedure. We have a wait list of about 6 to 9 months in general. We've got 2 surgeons doing that in London. Nobody in Hamilton. The next center is in Toronto. Right? So that's DBS. Then came this idea that if it's possible for us to give the same drug that we talked about, pharmacotherapy back again, that works really well in a different way. So what have we talked about? We've talked about oral medication and levodopa and those things. We talked about non-invasive stimulation tech that is now being developed, hopefully useful. We talked about invasive brain stimulation tech. And now we're taking the same drug, levodopa, that worked and is working so well orally, and using that, repurposing it to give it in a different way. So this is the next update in terms of how to give. This is not new. This has been around for 20 years in Europe, in Canada now at least 10 years. And this is levodopa, carbidopa in the intestine. Why do we do that? Well, the reason that levodopa and protein and all of these things matter is because, unfortunately, that drug is not absorbed through your gums, under your tongue, in your esophagus, in your stomach. It's absorbed in a very small portion of the small bowel called the jejunum. And in fact, it's absorbed in a specific way where transporters take that levodopa and make it cross into the blood, and then that crosses into the brain. And the loss is huge. Even with all of the tech that we have, we lose about 90% of what is taken orally, and only 10% actually makes it into the brain, even today. Right? So even today, with all of the other enzymes and inhibitors that we have in that list that I earlier showed you. So one way to do delivery and avoid all of this GI system is to make a hole into the stomach and float a tube and put it right there. But unfortunately, you can't just do that with the regular levodopa. You could, but you'd have to crush it, make it. And in fact, when I was training in the early 90s, we used to make what was called liquid levodopa. And what we would do is, for those patients who had a very brittle margin, give a little more and it's too much. Little less, it's too little. And we had to give these patients every 45 minutes little bits of levodopa. Well, how do you achieve that? You can't do that with a tablet. It falls apart. So we used to have patients take 10 tablets of the 100/25 yellow, crush it, put it in a drink, high C, 2 tablets of 1,000 milligrams of vitamin C, and shake it up, put it in a dark bottle, and pour it out into a teaspoon, and take it every 45 minutes or every hour like this. A pain in the rear end, because you'd spill it. You had to make it every day. But for those patients that had that very brittle, sort of razor's edge kind of therapeutic window, is our medical lingo, which means that, what I said, the boundary, you fall off, this side is a cliff, the other side is a mountain, you're walking, and that's how some of these patients are, brittle Parkinsonian patients. Then we had to do that. So came this technology where a special gel pack is actually made, and this is an AbbVie product, who are sponsors, I think, one of the main sponsors of this conference. And here's that gel pack. So this is LCIG, levodopa-carbidopa intestinal gel. And the idea is to provide that continuous delivery to improve, but it is a surgical procedure. You have to have a hole in the stomach. Somebody has to do that procedure, a gastroenterologist that's interested in doing that, and then you carry a pump, right? And then that pump is this thing, and it pumps continuously into that jejunum. And so, as you said, implanted tube directly into the duodenum or upper jejunum, bypasses the stomach, and all of the GI issues that are there. It's not the next thing to slice bread. It still has to get to the brain, and the brain has to do its thing. I mean, if the brain didn't do its thing, this wouldn't matter at all. And so the external pump is programmed just like we programmed the DBS device to give you a continuous flow for approximately 16 hours through the day. At nighttime, you can take oral medicine, and then you can take extra as you need, boosts if you need. Right? So that is the LCIG system, and we've been using it close to 10 years now, 7, 8 years in London, something like that. We've got a handful of patients on that, right? And across Canada, there are a couple of hundred patients that are like this. But again, the problem remains that the tube can get plugged, patients twirl it, you get caught, you go play tennis and fall on the ground. No, you have to disconnect it when you do that. And if you're playing tennis, you probably don't need this anyway, the LCIG. So has come the next advance, the next update, this thing called phospholevodopa, phoscarbidopa. So, how we are going backwards. And so levodopa, carbidopa, and I can tell you that many physicians outside think that L-dopa is simply because I don't want to say the word dopamine. No. It's an inert compound. It is not dopamine. L-dopa is L,3,4-dihydroxyphenylalanine. That's what the DOPA stands for. It is not dopamine with the mean cut off. No. It actually doesn't do anything. It needs to be converted to dopamine, right? And so that means you need cellular enzymatic processes to make the dopamine. Phospholevodopa is a step before that. So there's phos to levodopa to dopamine. Follow the yeah. So we eventually will get to the point where we're out to this side. So, but the idea behind this is that levodopa is very caustic. Caustic, not costly, caustic. So early days, people were trying to give IV levodopa, and it caused a lot of problems at the venous site, so you can't use it. Right? And the other one, the gel, of course, is thick gel, so you can't give it any other way intravenously, etc. You'll just plug the vein. So, or subcutaneously. So in fact, when tests were being done with IV, and I was involved in them when I was a resident, if it leaked, it caused a tremendous amount of injury to the skin, right? So because it causes vasculitis, it causes inflammation of vessels. So for all these years, we've had no other delivery of levodopa except by mouth, and it remains the same way today, except, and that's a problem, right? Because you've got somebody in the ICU who has had a major surgical procedure, can't take anything by mouth, Parkinson's disease, we're done. We have no way to deliver levodopa, the best drug on the market, to this person, because it's not, that's where we need to go. And so because of that, it's been, it always causes trauma for the neurologist when the patient with Parkinson's is in the ICU and the ICU doctor saying, well, what do we do with their meds? I have nothing to, so we had apomorphine, which was an injection, but unfortunately it was a transient 4-day, came to Canada, it was excellent, and then got pulled off the market last year, or early this year, because of lack of sales. Phospholevodopa, phoscarbidopa is a subcutaneous infusion, right? So now the technology has moved to the point where same pump, except for instead of having that duodopa pump going into the stomach, it's subcutaneous, right? And you have to administer it. So you don't need a gastroenterologist, but you need the person capable enough of being able to do that, right? So it is this kind of thing. I'll show you a couple of pictures. Not yet on the market, but very soon. It's another AbbVie product. So for treatment of motor fluctuation in advanced levodopa-responsive patients, right? And it's a 24-hour continuous infusion, and depending on the amount that you're getting, you could actually be able to use this for 3 days. So if you imagine you're going away for the weekend, you have that done, Saturday, Sunday, you go back, wherever you're going to your cottage, come back. Probably if you're going to Toronto, you'll be stuck in traffic for those 2 days. But at the same time, if you do get to your cottage and or just turn around and come back, you'll be able to use this pump for those 3 days, right? And then it comes off, and you move to another site and move to another site and that kind of a thing. So this delivery system is a new thing. It's been developed for many years in terms of the technology, but the compound is a new compound, which is where the intellectual property, so-called, or development discovery lies. And it comes with a whole bunch of things, and whoever will qualify, we will have to teach. The beauty of DBS is that it's implanted and you have to do nothing. It's all under the skin, and we do everything. Whereas here, phospholevodopa is duodopa gel that you get into the stomach is somewhere in between, where the surgeon puts it in. You have to basically flush it and change the cassette. We do the programming. Here, you do everything. There's no surgeon, no neurosurgeon, no gastroenterologist, just the patient and or caregiver. So the therapeutic intervention is in the patient's hands, right? And here's the diagram from AbbVie. We won't have to go through all of this, but the idea is that you open the bottle, you load the syringe, put it in this pump, start the pump, attach the cannula to your skin, administer therapy. So you can imagine that there are going to be obvious limitations. Somebody with bad tremor, if they're the only person doing it, this is going to be difficult to be able to get. And right, and so not a joke, it's a practical thing that we have to consider, because when you want to administer any therapy, the patient and caregiver have to have the ability, the knowledge, the comfort to be able to do that. However, again, you can imagine in the ICU, somebody like this, it would be of benefit to us, even if it's transient in that individual, but hopefully for those people that have the freedom to be able to go out and use this therapy. Right? So again, individually administered, we can do the same thing, hourly infusion, loading dose, extra dose, as we had for the stomach pump. Okay. So that's where the therapeutics of pharmacotherapy, electrical stimulation, repurposing and giving pumps using the same levodopa ends. That's symptomatic therapy, quality of life, activities of daily living, etc. But then Parkinson's disease is a disease. So a whole large amount of chapter of this disease treatment is to tackle the illness itself. Right from 30, 40 years ago of what we call neuroprotection, as we talked about exercise briefly, slowing the disease, slowing the pathology, treating the pathology, etc. So that's not a new thing. Years ago, we had a clinical trial where the idea was to use a drug that attacked an enzyme called a kinase, right? So a kinase, a mixed lineage kinase to be specific. And the idea was that these enzymes that exist in cells are toxic to the cell if they don't function, etc. So to try to actually target the pathology of the disease, not because if you treated the cells, then you won't need the symptomatic therapy, isn't it? Right? And so if you dig a well in your backyard, you won't need the water to be pumped from the city. So that's the idea behind trying to get to the pathology. So what is the pathology of Parkinson's disease? And this is where the debate is huge. But classically, Parkinson's disease is called a synucleinopathy. I didn't want to put that word because, what does that mean? That means there's a protein called alpha-synuclein, and we won't ask you to spell it, but alpha-synuclein is a protein that accumulates in the cells, whether it's toxic to the cells, whether it's because the cells are already dying that the protein accumulates, is the big debate. Whether it even means anything, who knows? At this point is where the debate is. But if you were to do pathology in a person that passed away and we looked at their brain, you will see accumulation of this thing called Lewy body, described by Frederick Lewy in the early 1900s, and now known to contain this protein called alpha-synuclein. So a lot of interest, obviously, is that, it's a synuclein disease, let's get rid of the synuclein. Maybe that will help the cells. Why? Because if the cells are accumulating garbage, this abnormal synuclein, and that's causing injury to the cells, let's reduce. So attack the pathology. If you attack the pathology, you save the cell, you don't get the symptoms, or you stop the disease. Makes sense, except we're not sure that this is the actual pathogenesis of Parkinson's disease. However, given the field's power, like the Alzheimer's disease drug that's coming to the market in the US, lots of problems with that one, but there's so much pressure, right, to want to have therapy that led to this. So alpha-synuclein accumulation protein, main pathology. Protein is present within the neurons, and this is normal that it's present in the neurons. Again, alpha-synuclein is present in our bodies, in our brains, even those that don't have Parkinson's disease. Normal protein, right? And so the idea, the concept, as I just said, is that abnormal amounts of it, and hence we should use some technique to reducing this alpha-synuclein, get rid of that synuclein from the, right? And so 2 large studies were initiated, and I'm going to show you those. The first one is Pasadena study, which is a phase 2 study, phase 2/3 study of anti-alpha-synuclein antibody. So remember how we have antigen, which is, let's say, the bacteria, and the antibody that you make to kill the bacteria, or something that gets rid of the bad things. So antigen, in this case, would be the alpha-synuclein. Antibody would be the anti-alpha-synuclein, something that sucks up that alpha-synuclein and gets rid of it, right? So 3-part randomized, blah, blah. It's, we like to say all these things to make us sound intelligent. And so 1,500 high dose. So basically, some people got a large amount, some people got a small amount, some people got nothing, right? And the idea was to see that this drug, prasinezumab, which is a humanized human, right? So it's not from animals, monoclonal antibody that selectively targeted this aggregated clumps of alpha-synuclein in a particular part of the protein to and then suck it out and throw it out. That was the idea, called the Pasadena study. And here's the New England Journal paper. This is a summary that they put together. The trial failed. What that means is that both 1,500, so here's the placebo, here's the 4,500 milligram, and here's the 1,500 milligram. And this is the change in score of what we call the Unified Parkinson Disease Rating Scale. Remember that little blob at the first slide? Bradykinesia, rigidity, tremor, blah, blah, blah. All of that is put together in a complex exam. Many of you that have come to our clinic, when you get to tap fingers, open hand, tap legs, walk, etc. That's part of the UPDRS. And that's the symptomatic improvement in the motor syndrome of Parkinson's disease. Unfortunately, as you see that, in fact, both placebo and the other 2 dosages didn't really show a statistically significant difference. Even placebo had a 9.4 worsening score, a change in the UPDRS, but on active treatment, you still had almost 8.8 and 7.4. And the weird thing was that the higher dose was worse than the lower dose, which you'd normally expect that, you have 1 steak and 2 steaks is even better. But unfortunately, that didn't work out that way. And so this trial failed. So the conclusion was that the monoclonal antibody, prasinezumab, as compared to placebo, did not show any change in disease progression at 52 weeks. There's some data that at 104 weeks, there's some change between those 2. And this is the other graphical. Basically, all you got to see is that everything is all one on top of each other. Right? So whether it's change in score to the UPDRS, part 1, 2, 3, part 3, which is the motor score, placebo slightly worse than the other 2, but not enough at the end point of 52 weeks. They basically collapsed into 1. And this, which shows that there was a delayed design, see week 104, so some people got nothing, and then they got converted. And the idea was that if you delayed the treatment, those people would be worse than who got the treatment early, right? So if I gave you water right at the start, and you were not thirsty anymore. But if I waited for 2 hours, now you're really thirsty, and then I gave you the water, that no matter what, at 3 hours later, the ones that got the water later would still remain thirstier than the ones that got it early, right? And so, but that's what we call delayed design, delayed start design. But even with that delayed start group, by the time they got to that end of 104 weeks, they basically largely collapsed into each other. This begs the question, is alpha-synuclein doing anything at all in terms of even a pathology, so that reducing it doesn't make any difference, right? Yeah, so then we go on to the second study, basically the same thing. This is now another drug, the cinpanemab, which is another monoclonal antibody, essentially showed the same thing. In fact, in this case, placebo ended up being slightly better than the drug, which is always a bad thing, right? It's much cheaper to give the placebo. Yeah, just water, it's a good idea, actually. In fact, water is not a placebo. What I wanted to show in this slide was that outside of the UPDRS, other things were used, which is imaging. If you look at imaging and how much dopamine is present after this in the brain, didn't show any difference either. And that's the same thing. Then there was another study that was published in the last year, very depressing in the last year for some of us, but at the same time, I think it calls to question that we need to question before you leap in these complicated conditions. One of the theories of Parkinson's or other neurodegenerative diseases is the presence of iron and how toxic iron is to the brain. So this trial was with deferriprone, which is an iron-reducing agent, and reducing iron, unfortunately, the same thing happened. In fact, the conclusion is that patients with newly diagnosed Parkinson's disease who would never receive dopaminergic therapy, deferriprone did not slow disease progression and actually caused worsening. And side effects were much higher. So deferriprone not to be used in patients with Parkinson's disease because iron deposition is very common on MRI scans in patients with Parkinson's disease, and hence the idea, right? And then a couple of last things on to now really getting down. Remember we talked about oral medicine that goes to the whole brain, then stimulation, deep brain stimulation, then pump therapy in the stomach, now antibodies that go to the, and now really specific going inside the cell to the mitochondria, which is where energy is manufactured. And all neurodegenerative disease, the feeling is that it's because we don't manufacture enough energy in the brain, and hence the cells just can't get rid of garbage, can't serve things that need to be served, right? In terms of if you run out of gas before the food is cooked, we're all going to be hungry, right? And so that's the kind of thing that people have been targeting to try and use against the mitochondria. Why? Because the mitochondria are also involved in processing all the things, the alpha-synuclein that we talked about, it needs energy to process. So let's see if we can, and in Parkinson's disease, failure of mitochondrial energy generation has been talked about as one of the most important reasons why, in fact, the most important reason why Parkinson might occur. And this is because many years ago, there was a toxic syndrome. I only have a few more slides. There was a toxic syndrome that occurred in the early 80s with a compound called MPTP, methylphenyl tetrahydropyridine, MPTP. And MPTP is a compound that was mistakenly manufactured by drug addicts in California, San Francisco. They were trying to make Demerol, which is meperidine, in their basement. And unfortunately, you need to be a good chemist to make these things. They made this thing called methylphenylpyridinium, MPP plus, which is an analog of meperidine, Demerol, thought it was Demerol, injected themselves, and it killed their brain cells that made dopamine. And they came into the emergency department like this, like a board, right? And basically acute Parkinsonism. It wasn't Parkinson's disease. The good thing was that led to the discovery of making animal models of Parkinsonism. Now, none of the animals that we work with, and we have a big lab over the years that I've had with rodents and people that then made primate models using MPTP, none of those animals ever get our kind of human Parkinson's disease, ever. So you use this MPTP to make a model, right, to generate. And what it showed, that when you looked at the pathology of what MPTP did, guess what it did? It killed mitochondria. And mitochondrial energy failure then became, if MPTP, which causes our bradykinesia, rigidity, Parkinsonism in animals, and it kills mitochondria, maybe we should be looking at human Parkinson's disease as a mitochondrial disease, right? And this is that big, and it's true. It is actually correct that enzymatic, and mitochondria are very, very complicated. They're actually bacteria, by the way. And when evolution occurred, cellular systems took bacteria, mitochondria, and put them inside us, inside our cells, so that we have nuclear DNA, which makes all of our other proteins, and mitochondrial DNA, which are bacteria. And they make the ATP, adenosine triphosphate, which is the energy in all our body parts, muscle, heart, doesn't matter, liver, brain. Right? So, and in Parkinson's disease, mitochondrial failure being so important, of course, people are looking at targeting those kinds of things. And this is all very recent stuff. I mean, it's literally within months of where we are at today. So the idea is that because many molecules, this pink one, in particular one, Parkin, which is actually a genetic form of Parkinson's disease. So if you have an abnormality in Parkin or PINK1, which are constituents in our cells related to mitochondrial function, if you have a gene abnormality in Parkin, you get young onset Parkinson's disease. And we've got patients in my practice who have Parkinson in your 20s and 30s, you'll get Parkinson's disease. PINK1 is very similar, right? And so the idea is that these molecules work with the mitochondria, and since gene dysfunction in these molecules can cause young onset Parkinson's disease, by affecting mitochondria, can we develop compounds that directly target these substrates to help the mitochondria in patients with typical Parkinson's disease become more efficient. And so there's a compound that, in fact, AbbVie, the people that are sitting back who are also have bought. It's called mitokinin MTK458. So they just bought this company. No data really exists in humans by any means at this point in time. And the idea is that these compounds, this mitokinin drug, will target or will try to target these damaged mitochondria by slowing down or increasing, depending on killing bad mitochondria, helping new mitochondria grow, and then reducing cell death. And the idea is doing this through increasing in this activity of this thing called PINK1. So mitokinin is a drug that's being looked at as one of the, and then another one is this NADPH. NADPH is another substrate that provides energy in the cell. And this study actually has been done by a friend of mine. We share a big grant together called StratPark, but this is NADPARK. It's been published. So this is NAD, nicotinamide adenosine diphosphate levels. So NAD levels, which alter cerebral metabolism. And the idea is now you're really getting down to the cellular ATP energy production to try and help with these neurodegenerative diseases. And that's it. I see that I need to stop talking. And so, you know, subtle hints by the time I'm handcuffed and gagged. So thank you very much.